Hello and welcome to the first of a small series of screencasts focusing on pharmacology. I know that this is for most of you a bit of a gap that we need to help you to fill as you start off on your nursing degree apprenticeship with us. This first introductory session will focus on some of the nuts and bolts and some of the terminology. I apologise in advance if some of this is a bit basic for you because you've already covered it or you're already familiar. But for some of you, getting the complex terminology and beginning to understand some of the processes is really important. The main thrust of this particular screencast will be to look at the absorption, distribution, metabolism and excretion of the drug, and looking at some learning activities so that you are being active but also translating some of your experience in practice and applying some of your learning to patient care and to your overall underpinning knowledge. Here are the learning outcomes for this particular screencast. Find out a bit more about common medicines, but don't just rely on the stimulus materials that are in this presentation. Do dig around and think about other things that you're coming across in your practice and with patients so that you begin to understand better the different families of medicines, and then you feel that your knowledge base is growing. We will be looking at how drugs work and differentiating between pharmacokinetics, pharmacodynamics, and pharmacotherapeutic effects. 3 big words. So hopefully by the end of this screencast and the activities, they will no longer feel like gobbledygook words to you. Outline the nurse's role in drug administration by looking at some of the rules and the rights of drug administration, and provide for you a couple of useful apps and a useful way into Athens Online, which again might be very useful resources to tuck away and will help you become more confident as a digital learner. Pharmacology is the study of drugs and their interactions on the body. And there are many different types and some complexities, so hopefully this walkthrough will begin to set a nice foundation for you. This slide begins to unpack a little bit some of this difficult terminology. So if we start at the bottom right-hand corner, pharmacy and pharmacists prepare the suitable dosage from prescriptions and issue medicines for patients and patient care. Pharmacotherapeutics, so if we uncap the pharmaco from the therapeutics, you can see that then means that use of drugs therapeutically, in other words, to help in managing symptoms or perhaps in preventing further symptoms and in health and in treating illness and disease. Top left-hand corner, pharmacokinetics. So pharma, about drugs. Kinetics, it's about what the body does to the drug, because clearly our bodies interact with the materials that are either ingested, delivered intravenously and subcutaneously, and so on. And the final title is pharmacodynamics. So what the drug does to the body, how the drug affects bodily symptoms. Right at the bottom in red, toxicology. It's absolutely fair to say that while drugs can be used therapeutically, many can cause side effects and symptoms. Some are toxic and some need very careful monitoring, as we shall see as you progress. So pharmacology, pharmakon, to do with chemicals, to do with biological interactions. Logos, to do with logic, knowledge. One of the texts that we're going to direct you to is the Fundamentals of Clinical Pharmacology, which we have available as a PDF for you to dip into. It is the 3rd edition, not the most recent one, but the way that drugs act and interact and the foundation stones don't change, even though medicines and what is known does. Many drugs have different names. There is the chemical name, the scientific name, that describes how it works and how it is comprised. In other words, its molecular structure. The generic or non-proprietary name. The generic variant of a drug is normally much cheaper than proprietary or trade-named drugs. Hence, there's a big emphasis on the prescribing of generic medicines, if possible, to drive down the cost of prescribing, which is very considerable to the NHS. And then the 3rd is the trade or proprietary name, which is the copyrighted name by a particular drug company. They are protected by copyright and can be considerably more expensive. As you read, see if you can discover some examples of different prices and the difference between the proprietary and the generic name. For example, in lipid-reducing drugs such as statins. Okay, pharmacotherapeutics, so that's about curing disease and relief and management of symptoms and treatment plans. A definition of a drug as a substance or product that is used or intended to use to modify physiological systems or pathophysiological symptoms and states to try and help and benefit the recipient. Of course, in some cases, drugs may have toxic effects and side effects, so the intended use and the intended benefit may not be fully realised. Some drugs are naturally formed and available within the body. For example, as you will know from your anatomy and physiology, things like adrenaline, hormones like thyroxine, testosterone, estrogen. Some drugs, of course, are chemically synthesized outside the body and manufactured, and there are some examples given on this slide. As the word drug can have negative and stigmatizing connotations, there's a tendency to call drugs for recreational, religious medicines. A medicine as a term for a drug that is used therapeutically. So, drugs for recreational and religious use, things like cannabis, cocaine, and so on. And a medicine is the term given for the therapeutically used drug. Clearly, there are different relevant points depending on what point in the lifespan the patient is, from infant right through to people facing the end of their life. And some medicines aim to cure, such as antibiotics. Others are preventative, in other words, providing prophylaxis to prevent disease or to reduce risk factors. A salutary and very useful quotation. Poisons in small doses are the best medicine, and useful medicines in too large doses are poisonous. So we need to be careful about toxicity, and some of the medicines that you will be using yourself or using with patients will be ones where there isn't much difference between a small therapeutic dose and a toxic dose. Watch out for this as we move further forward. Many drugs and medicines come from the natural world and from plants. There are great examples of old-fashioned medicines now being investigated and researched and found to have therapeutic properties that may have been poo-pooed. On this slide are some examples of minerals, plants, microorganisms, and others produced by genetic engineering. So a wide span, and the chase is on to discover new and different sources, for example, for some of the microorganisms, for antibiotics, because of the antibiotic resistances that are now occurring. Okay, what I didn't say at the beginning is, please stop and start this presentation as often as you like. Here is an activity. I'll talk through it. Here I do want you to stop it so that you have time to do the activity and think, but also perhaps make some notes on what we've covered so far. So the first activity, think about the medicines you've taken over the last year. Some may have been prescribed. So why are you taking them? Do you understand how they work? Do you know what the contraindications and side effects might be? Some might have been bought over the counter at your local pharmacy or supermarket. Important to realise that often healthcare workers don't ask about over-the-counter medicines, only think about prescribed medicines when they're looking at the plan of care for patients. Identify 2 most common medicines your patients, residents, service users receive, and make a note of that. You may already know a lot about them, but you may also want or need to do further investigation to find out more about how they work and what you might be looking out for when administering medicines and watching how they are affecting the patient therapeutically. Okay, so pause and stop the presentation now. Take as much time as you like and then start again when you finish this. To help you in your learning, there is a PDF copy of Clinical Pharmacology 3rd edition. This is really quite an accessible book. You may find later on that you will need other books, but it should give you a good way in and enable you to quite quickly whiz about using the index and the contents list to find particular things that are being talked about in this screencast and the others to follow, but also that you want to know a little bit more about as you try and work out the what, the why and the how. Drugs, medicines are generally classified according to their major clinical use and to the site of action or the bodily system on which they have a therapeutic effect. Okay, if you're not sure what an antihypertensive is, you might wish to whip out a medical dictionary so that you can get information, so that you understand what that term means, and of course, flick to the PDF of Clinical Pharmacology where it will explain this. Given some examples of antihypertensives, now might be a time, again, to stop the presentation and to decide if you'd like to look up and find out a little bit about them, particularly if any of your patients are receiving that medication. So drugs are classified according to the site of their action. A loop diuretic, remember your physiology. What does that relate to? What is a loop diuretic? Why might your patients be receiving them? How they act molecularly, so things about enzymes and receptors, and how they work in terms of their structure. Tricyclic antidepressants are a particular type of antidepressant, quite old-fashioned now, but can have great use. Okay, to help you find out more, the British National Formulary, BNF, is available as an app. On this slide, I've given you lots of information so that you should be able to get for your smartphone or tablet the app version. So make sure you don't pay for a copy. You can get it free, and there is a link once you have the app to Open Athens, which allows you to get lots of access to fantastic literature. The next screen will show you the BNF app, so you know that you're getting the right one. It has medications for adults and children all in one app. And the slide after that will show you what the welcome screen to Open Athens looks like, so that you can complete your registration to Open Athens, get your login details, and then reward yourself with a lovely cup of tea, coffee, cocoa, preferably not wine or gin if you're in study mode. Okay, this screen shows you the BNF app, so happy hunting and good luck in downloading. And this screen shows you the welcome screen you'll get when you click the link. Do register for an Open Athens account. It's tremendously useful and will give you lots and lots and lots of information. Time for a nice cup of tea and a biscuit. Don't forget that you will need a medical dictionary or books and literature that help you with the terminology. And don't forget, whether it is on your tablet, laptop or notepad, to make notes, take stock, take pause. Again, do stop the screencast before you move on. So now we get to the word pharmacodynamics. This is how the body is affected by the drug, the mechanisms of the drug interaction. So how at cell level the drug interacts and makes changes in the body. So it's at cell level that matters. Some drugs are called agonists. AGONIST. By stimulating or blocking receptors. Others are called antagonists. So an antagonist prevents a response from occurring. Pharmacokinetics. This refers to the drug action as it moves through the body, how it's absorbed, which of course depends on the route of administration, how it's distributed, how it's metabolized, and then how it's excreted from the body, known as ADME, A-D-M-E. Okay, so what the body does to the drug, and an interesting little cartoon, because clearly, just because somebody has had an intramuscular injection does not mean that that bit of the body is where the therapeutic effect takes place. This would be a good time to get into the Clinical Pharmacology Made Easy PDF textbook and look at page 7 and the next few pages, where there is some really useful accessible information to explain pharmacokinetics and absorption with interesting cartoons and thinking points, which will help you understand better about how drugs are absorbed, whether it's active or passive transport, and the way in which medicines are distributed, metabolized and excreted. Also explains some of the things that may make a difference, like pain and stress. If somebody is being given oral medication, what effect might high-fat meals or solid foods or starvation have? So it's real mine of information. So again, stop the screencast and have a read and make some notes. Okay, so another activity, activity 2. Let's apply it a bit. You're probably feeling a bit overwhelmed now, so let's start with something that's very common that you, colleagues and your patients are likely to be taking, whether it's prescribed or over the counter. Very common drug, paracetamol. There are 7 things to think about, 7 points. What's the normal therapeutic dose? What routes of administration? How is it absorbed, distributed, metabolized and excreted? And why may paracetamol be indicated? This would be a good time to go to Open Athens and see whether there's any NICE or clinical knowledge summaries, known as CKS, or other current information about when paracetamol is indicated. Also give you the page numbers for clinical pharmacology, pages 96 to 98. Very useful and helpful, but please beware because it being an American textbook, the American term is used, which I have highlighted in red for you. Okay, so again, stop, pause, do this work and think through about what you now know about paracetamol that you might not have known before, because we will come back to paracetamol later. Welcome back. Okay, so you may well have quite a lot of experience of medicines management or observing others giving medicine, or need to think about it because this is a role that will be increasingly important to you in your development. So start thinking about what might be the rights of drug administration to keep patients safe and provide effective medicines management. By 9 rights, it is 9 things to get right. Given you the article that solidifies the 9 rights, you may, via Auntie Google, find that some people have teased this out to more than 9 rights, up to 12 or 13, I think. So you can always add to it. This is about the things that you need to correct, try and enhance to make sure that the patient is safe. Once you've done this, having again stopped the screencast, do move on to the next slide. But don't cheat, do think first before you move on. Okay, here are the 9 rights that Elliott and Liu 2010 give you. Of course, it's blindingly obvious. The right patient is receiving the right drug via the right route at the right time and being given the right dose. It's being documented in a correct way. It's being given for the right action with the right form, so an accurate prescription, and they're having the right response. Or are they? Herein lies some of the roots of why medication errors can be so common and why nurses so often are those who are involved in medication errors. Okay, pharmacotherapeutics, as mentioned earlier, is the use of drugs to treat diseases and to lower risk. The dose, clearly, whatever is prescribed to the patient, should be the correct dose, achieving a desired effect, so being therapeutic, without triggering harmful side effects or toxicity. During drug development, which has many phases, these are described in the clinical pharmacology book, experiments are used using tissues and cells, experimental animals, human volunteers, and finally patients, which is why it takes a long time and why it can be enormously expensive to develop new medicines. One very important thing is the notion of the therapeutic index. This is the measure of the difference between the therapeutic dose of a given medicine and the poisonous or toxic level. So the wider the gap, the higher the difference between the therapeutic dose and the dose that would provide toxicity. The wider or higher the difference, the safer the drug is. Measured by taking the ratio between the blood plasma level for a therapeutic dose and then the investigations which have established what dose is toxic. So 2 examples. The therapeutic index, TI of aspirin, is 3.5 and that of digoxin from foxgloves is less than 2. So check it out. Do you understand what this means and the implications to the patient? Is aspirin more or less likely to cause poisonous levels more easily? Is the therapeutic index of digoxin more or likely to cause concerns about the difference between the therapeutic dose and the toxic or poisonous level? Again, stop the screencast and have a think and read in your clinical pharmacology book and any other resources that might be useful. If you have patients regularly taking any of these medicines, you may wish to go back through the loop to find out more about how they're absorbed, how they're metabolized, and so on. The illustration on this slide shows you the dose response curve. It's taken from the clinical pharmacology book and demonstrates the difference in doses between the first drug, A, B, C, D points, and the second drug, Y, with point E. Okay, see if you understand what this means. And if you don't, go back to your clinical pharmacology book and also look at the next slide. This slide illustrates therapeutic effect, which is in the first part of the grid, demonstrated by the blue printing and the blue curve. The toxic effect with the red lettering and red curve, and shows the difference between the two as the therapeutic index, TI. Clearly, the closer the blue and the red are together, the more likely poisoning is to occur. The lower the therapeutic index, the more monitoring and difficulty there might be to titrate or balance the correct dose. The further apart the blue and red are, the more likely the drug is to be safer for longer. So it's very important that the right medicine is chosen and the doses are adjusted appropriately. Remembering that there are interpersonal variations between different people, that not everybody's body reacts the same, and knowing what we now know is that some drugs have a low therapeutic index, which needs regular monitoring and dose adjustments. And so here are some examples, including digoxin, which we looked at earlier, lithium, which is a mood stabilizer, and phenytoin, which is Epilim, for the treatment of epilepsy. So again, if you've got any patients on these drugs or others with a low therapeutic index, monitoring them, observing carefully for side effects is really important. Okay, why do you think medication errors happen? Stop and think about medication errors. Compare this with the 9 runts, or if you find 10, 11, 12 or 13. Use your experience and think about any policy or procedural issues in practice that make it more likely to lead to medication errors or less likely. If you've identified some difficulties, then what would you do to suggest that could better protect patients. Again, stop the screencast and have a little think and note down. And do share your learning with other members of the group and with your colleagues at work. Here are some examples of factors that can contribute to medication errors, by no means all. And I draw your attention to the bottom two, in that many of you will be working in community or in people's own homes or closer to home. Patients do not take medications as prescribed. They may not be fully concordant. We know that patients may take part of a course of antibiotics, feel better, and then not take them anymore. So they may not take them as prescribed, or if they have emotional or memory difficulties, they may not be able to fully understand how to take them properly. They may need some help, dosette boxes, for example, to help them to take medication more accurately. And medication sharing, not just between partners, husband and wives, but between neighbours. And sharing prescribed drugs, keeping medicines in places which mean that they are no longer safe to take, something that should be stored in a cool place, kept in a cupboard above the oven. So many things to think about. So don't just think about the context within a hospital environment, because many medication errors happen elsewhere, and many other healthcare workers and you yourselves in community practice may be able to think of ways of trying to protect or limit medication errors. So learning outcomes wise, we come to the end of this one. Whew, I hear you say. Are you able to outline the nurse's role in drug administration, to think through the nurse's role in terms of the 9 rules of drug administration and some of the key principles that you will use to make sure that you and your colleagues protect patients, discuss how drugs work, and differentiate between pharmacokinetics, pharmacodynamics, and pharmacotherapeutic effects. Hopefully, even if you can't go, yay, I've got them all, you're feeling more confident and you can review this and then you can start to apply it in everyday practice, but also to your scenarios and to your new learning during your first modules. And here, finally, are some references that will perhaps set you up to wider reading, which may help you.